Good afternoon, everyone, and thank you for joining today's webinar, Words Matter, Reducing the Stigma of Substance Use Disorder. Today's presentation is brought to you by the Southeast Addiction Technology Transfer Center as the National Center for Primary Care at Morehouse School of Medicine. Before we begin, I have a few brief technical considerations to share with you. We ask that all participants please keep their microphones muted throughout the webinar and to check their internet connection for optimal webinar experience. We also ask you to refer all technical issues and presenter questions to the welcome chat pod that's on your screen. There will be periodic stopping points throughout the webinar for Q&A, as well as time designated at the end of the webinar for discussion and Q&A. We now want to share with you a little bit of information about the National Center for Primary Care here at Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals serving in underserved areas, promoting access, effectiveness, and equity. I would now like to introduce today's moderator, Larissa Smith, Research Associate for the Southeast Addiction Technology Transfer Center. Larissa?
Good afternoon, everyone, and thank you for joining us. I just want to start by giving you guys a brief introduction to Ed Johnson and his work and familiarity in the area. Ed Johnson obtained his bachelor's degree from Auburn University and a master's degree in clinical counseling from CITEL. He currently serves the Carolinas and Kentucky as the program manager for the Southeast Addiction Technology Transfer Center, located at the National Center for Primary Care at Morehouse School of Medicine. He has over 25 years of experience in providing direct services to individuals with substance use disorders and co-occurring disorders, and has provided a number of trainings for the Southeast Addiction Technology Transfer Center and others in the same professional space around HIV and addiction, recovery-oriented systems of care, addiction recovery, addiction and opioid dependency, treatment issues related to lesbian, gay, and bisexual and transgender folks, and individuals with addiction, and also supervise individuals around addiction. He's currently credentialed as a licensed master addiction counselor, a certified clinical supervisor, and a licensed professional counselor. Ed, thank you for being here with us. We're lucky to have you.
Well, thank you for asking. So thank you for that wonderful introduction. The only thing I would jump in and say, the folks in South Carolina would get rather cranky if we didn't clarify that it was the Citadel that I got my master's at, but I just got
Sorry, a lot of C's in a row.
I know, but I just, as I told somebody one time, no, I didn't have to get dressed up in the uniform. I was part of the graduate college. What we're going to be talking about today a little bit is words. And sort of to set the stage, and this is a little bit more just to make sure to help out, that y'all, the folks who are on the call, know who we are. The addiction technology, there are 10 regional addiction technology transfer centers that the Substance Abuse and Mental Health Services Administration funds. The Southeast ATTC, which is based at the National Center for Primary Care at Morehouse School of Medicine. We cover, again, Alabama, Florida, Georgia, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee. I primarily focus on North Carolina and South Carolina and Kentucky, but we're all over the Southeast. This quote right here from President Obama sort of sums it all up. And I mean, to put this quote in context, he said it in Charleston, West Virginia, and if you're not aware, West Virginia has been particularly hard hit with the opioid epidemic. And he hit it right on the head when he said we can't fight the epidemic without removing the stigma. And what we're going to be talking about today has to do not just with the stigma, but basically what we as addiction professionals, we as behavioral health professionals, we as healthcare professionals, things that we can do to reduce the stigma by changing some of the words that we use. For folks that might not be totally familiar with it, it's important to understand that there are definitely levels of stigma associated with respect to substance use disorders and addiction. I mean, there's, of course, we make a big differentiation between alcohol and cigarettes, which are legal, and marijuana, cocaine, and other things which are illicit. Same, addictive potential, but thanks to the Harrison Act in the early part of the 20th century, one set is legal, the other isn't. There's also a very huge, different levels of stigma between, say, for example, somebody who uses heroin and somebody who has a problem with alcohol. Again, heroin is like, ooh, that's really bad. And of course, then you've got the method of use. I mean, people, having worked with folks with opioid use disorders for, 20 some odd years before I started here at the ATTC, you can, if somebody who is injecting, they're at the bottom of the pile. Somebody who's obtaining opioids and misusing opioid prescription meds, they're viewed at the top of the pile. I put the phrase "those people" in there because routinely, like any other stigmatized group of folks, folks who are not familiar with substance use disorders and people who have them, nicely refer to them as "those people," which in and of itself is pretty darn stigmatizing. And I should point out right about this point in time, I am a person in long-term recovery. I've been in recovery from substance use disorder coming up on 33 years. And, being one of those people, it sort of pains me. And I've reached a point in time in my life where I don't have a problem pointing that out to folks. Today my life is about recovery, and it's important for me. I'm a firm believer that, having received the gift of flight from recovery, having the ability to share that and to help other folks realize they can have the same gift. It's important. This is a nice quote from...
Ed, can I ask you, touch on something that piqued my interest before you move on to the next slide? You kind of talked a little bit about the distinction between illicit versus illicit, and what those types of categories do to stigmatization. And I was wondering if you thought, in addition to stigma from the public, the general public, there's also some stigma introduced with differential sentencing practices. For example, I know prior to the Fair Sentencing Act of 2010, 5 possessions of crack cocaine resulted in a minimum mandatory sentence of 5 years, with 50 grams resulting in a minimum mandatory sentence of 10 years versus 500 grams and 5,000 grams. So we're really talking about a 100-to-1 disparity. And I was wondering if you could talk a little bit about if you thought some of the differential sentencing practices play into some of this stigma across substance types.
Absolutely. A prime example, again, under President Obama, there was a move to combine at the National Institute of Health the National Institute of Drug Abuse and the National Institute of Alcohol Abuse and Alcoholism, and that was moving forward, and then all of a sudden it stopped. And basically why it stopped was that the Spirit Beverage Council, the lobbying agency for alcohol, raised such a fuss about not wanting their product associated with drugs that it was stopped.
Right.
But that absolutely has to do with it. I mean, the perception that, powdered cocaine is much higher up on, different from crack or injecting cocaine, that absolutely plays into it. And that's one of those, we could spend a whole hour talking about that. But
We
you
could,
are
just that
absolutely
topic.
right that you know, and it's one of those things that you know, and I'm just going to say this, and I'll say in advance if I hurt anybody's feelings, but um, there were people of color dying from opioid drug poisonings for a long time, and when it moved out to the suburbs, it suddenly became an epidemic, and that's just that. You know, and it is what it is. But it's important. Notice how in our next slide here that, you know, language, all of what we're talking about is language. You know, and if you look at that second bullet there, most folks don't understand, when they hear the word stigma, you know, a lot of times they'll think of the stigmata. But actually stigmata, or the stigma, is a Greek word. And basically it was a brand. It referred to a brand that was applied to somebody who was a slave, so they could be easily identified from freeborn citizens. So the fact that it's a mark of disgrace or dishonor, and the deal is, you're marginal. People with stigma are basically marginalized, and that's not a big surprise. But the whole point of our time together here is to help folks get it, how we can be part of the solution and not part of the problem. One of the things that's real important to get when we talk about this whole issue is that, and this is something that Gil Kurlikowski, who was President Obama's first Director of National Drug Control Policy, said, and what is highlighted in red as far as it's a chronic disease of the brain and it can be treated. And that's one of those things, and of course he follows it up with, it's not my opinion, it's not a political statement, it's a fact. Decades of research and study, you know, and we need to stop ignoring it, period. What I'd like to, oh,
So kind of
sure,
along those same veins. Sorry, we have a
okay,
little bit of a lag time. So kind of along those same veins, I'm wondering, you know, it's clear. Just as the statement says, it's not really up for debate whether addiction is an opinion. It's a chronic condition, and so I'm wondering along those lines, what do you think it would look like if we treated addiction like other chronic conditions such as hypertension or diabetes? Do you see a place for that in primary care settings or other settings?
absolutely. I think that, and we're moving in that direction slowly, but at some point in time, um, there will be specialized addiction services, which will, you know, fit in the category of what we refer to as addiction treatment now, that will be in the same category as cardiovascular specialty, gastrointestinal, orthopedics, that somebody will, you know, when they go to their primary care doctor, they will be then referred, you know, if they are identified. It's the same kind of deal as somebody shows up at their primary care doctor and they're in the process of having a heart attack. They get referred to the, you know, obviously the emergency room, but they'll get hooked up immediately with a cardiologist. You know, and no questions asked, boom, 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 and an appointment will be set up for them. They'll get a call to remind them to be there, exactly like that. And I think if we, you know, again, if you look at it from the perspective of what happens the first time you go, every time you go into the doctor's office, first thing they do, take your weight and check your blood pressure. Boom. If the blood pressure is elevated, they take action. We need to be treating, and we have what's called SBIRT, screening, brief intervention, referral to treatment, that it can be identified and dealt with right from the get-go. So absolutely it needs to be in primary care, because again, too, substance use disorders impact every other
Right.
chronic medical condition. They do. So
Right.
why don't we go to our
And even from a continuity of care perspective, just as you pointed out, substance use disorders do impact other chronic conditions. So if you find a place for it where you're receiving your other care, all other outcomes should
And
be
there have
better.
been significant studies where they have had folks that had more than one chronic medical condition, like, say, for example, diabetes, um, mental health issues, and alcohol, that when they received very, very significant case management, the amount of money that was saved because of increased adherence and increased recovery was just amazing. So why don't we do the polling question? What I'd like folks to ring in on is, do you believe addiction is a chronic medical condition or not? Yes or no? Going once, going twice. Why don't we close it out now? How about that? I'll be honest, this was sort of a loaded question. The majority of folks, for those of you that can't see, roughly, 96% of the folks said that, yeah, they agree that it's a chronic medical condition, and 4% don't. What we're going to spend the rest of the time that we've got together talking about is, okay, if in fact it is a chronic medical condition, like we say it is. I mean, I've been in the field for a while, and we've always referred to it as a chronic medical condition, but the question will be, is the language we use consistent with that? And more importantly, is the way we treat substance use disorders consistent with the way we treat other chronic medical conditions? And if addiction is a chronic medical condition, what I'd like folks to think about with all of what we're going to be talking about is words that we use, the treatment modality for substance use disorders. Is it the same as would be for type 2 diabetes, hypertension, asthma, or any other chronic medical condition? And if it's not, then either we need to stop referring to it as a chronic medical condition, or we need to change the way that we're talking about, and treating substance use disorders. One of the deals that we're going to find out, or that I'm guessing y'all might notice, a lot of the terms that we currently use, that we've been using ever since I've been in the field, are really more morally judgmental than medical. And as a result of that, if you notice that last bullet there, we do tend to treat folks with substance use disorders way different than we do folks with other chronic medical conditions. And I'll share with you one brief example that was John Kelly and colleagues who were up in Harvard did a lot of work around this topic. And one of the things they did, and this was, again, in a healthcare setting, a behavioral healthcare setting, they had two case studies that folks were randomized, and one of them, the case study, referred to Mr. Williams as a person with substance use disorder. The other, Mr. Williams was referred to as a person who was a substance abuser. And then they had to take a computer survey which measured empathy, things like that. And what clearly came out is the person who people who had Mr. Williams as a substance abuser felt overwhelmingly, like 80 to 20%, that he brought it on himself. It was his own fault. Why are we wasting resources on this person? He just needs to get serious, yada, 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 just needs to go away. The folks that had him as somebody with a substance use disorder was the exact opposite. That one word. This right here is something that we at Southeast HETC developed, and there's a place where you can go. You can go to our website and get it, but you can also go to Faces and Voices of Recovery's website and download a copy of this. We're not going to go over all of this, but we're going to go over part of it. And basically it's broken down into current terminology and alternative terminology, and it's important for folks to understand. We're not talking, if you don't use the right word, you're a bad counselor. What we're talking about is getting folks to think. Are there words or are there phrases or are there ways of looking at certain aspects of what we've done as far as treatment as usual that we might want to rethink in the context of addiction as a medical condition and, looking at focusing on recovery as opposed to the addiction. Okay? Yeah, go ahead.
And I think that is such an important resource. And if you don't mind just repeating where folks can find that again, kind of anecdotally, I used to have a job where I was hired to align some state policies with national level policies. And I wrote a memo kind of proposing some things that I wanted to do that were kind of standard operating procedure really in some more progressive states than the state I was hired to do the work in. And I sent out a memo and I got some kickback saying, the political climate doesn't allow for this. It's not really the right time to make these kind of shifts. And I went into my drawer. I have a kind of set of spelling and resource books just very quickly that I can always take out. And I used a thesaurus and I literally changed words. I didn't change content. I didn't change intent or meaning or even policy outcomes or aims. I just used the thesaurus to change some of the words, and that changed the framing enough that I was able to get done what I wanted to do. And for me, that's a story I always hold dear. I always think about how my language is relaying the message that I intend to relay because, like I said, nothing substantial or even consequential really changed with the ask, but what did shift is the word and the verbiage. So I think that's a really important resource and a really important thing for folks to remember. So I like that you shared that.
One other thing, and I mean, this is one of those anonymous quotes most folks might have heard: be aware of your thoughts, they become your words. Be aware of your words, they become your actions. Be aware of your actions because they become your destiny. And when we're finishing up, we're going to talk a little about person-first language, but one quick interject here that I encourage folks a lot of times, especially folks that have been, in the addiction treatment field for a while, and they think in terms of so often it's referred to as the flavor of the month. It's like, oh Lord, if we, this is the latest and greatest from whatever, if we just ride it out, it'll go away. And there's also a huge emphasis nowadays on the whole issue of political correctness. And what we're going to be talking about is not political correctness as much as it is from the standpoint of treating the people that we serve, treating the people that we work with dignity and respect, and accuracy that all of our ethical canons mandate that we do. The first term, because it is by far the most ubiquitous, and it's also, as I just got through mentioning, one of the most damning, is this whole term, either substance abuse, drug abuse, prescription drug abuse, and it's pretty darn behavioral, judgmental, stigmatizing. And one of the things that again, research has been done on, that the general public, even though folks in the field of substance use disorder treatment might understand what they were getting at, the general public, when they hear substance abuse or drug abuse, they put that in the same category as domestic abuse and child abuse, and needless to say, that's not a real good neighborhood to hang out in. And it's important to understand, too, that it's not an accurate term, as in substance abuse, because if you stop and think about it, domestic abuse, okay, the perpetrator abuses their partner. Child abuse, perpetrator abuses, the child. I'll be honest with you, being in long-term recovery back in the day when I was still very much in active addiction, I did not abuse my substances. I took very good care of my substances. My substances abused me, but I took pretty darn good care of them. And so it's not an accurate term either. The DSM-5. Yo, go ahead.
And that, I'm sorry. And that, you know what, that kind of goes back to, if we think about our kind of standard test prep, and this is analogous to that, right? What you're really wanting to make sure that the terms you're using are actually the terms that you intend, and they're conveying what you intend for them to convey. That point that you brought up was really salient to me, because I just kind of, like I said, thought back to my SAT prep, and those line of studying and questions. Well, this is analogous to that. How, you know? So how is substance abuse analogous? Is substance abuse analogous to child abuse or domestic abuse, you know? And so it's important. These things matter.
One of the things, I mean, and it's one of those deals, you know, using the term addiction or substance use disorder, again, is a more accurate, you know, again, a more accurate term, more medically focused. Another one that, you know, is important to understand is, you know, this whole issue of prescription drug abuse. Again, a more accurate medical term is prescription drug misuse. Okay? The person is misusing the prescription medication. It might not be their prescription. They might be taking more, whatever, but they're misusing it. They're not abusing it. And the last thing, especially, and this comes up a lot when you're talking about, you know, women who have opioid use disorder and are pregnant, and the phrase always comes up, it's like that the baby's going to be born addicted. And it's like, no, the baby is born dependent on opioids, just like anybody else who's used opioids appropriately. That's one of the deals about opioids. There are a whole bunch of other things that have to happen in order for somebody to meet the criteria of addiction, and most neonatal intensive care folks don't engage in those kind of things. Another term that folks might want to think about, the whole, and we use it a lot, denial. You know, with other medical conditions, the term that is used is ambivalence. And if you stop and think about it, this is a nice definition of ambivalence by Miller and Rolnick, the folks who brought you motivational interviewing. But the important thing to understand is the take-home from that is feeling two ways about the same thing. And if you stop and think about, most folks know somebody who has type 2 diabetes or has hypertension. The person who has type 2 diabetes, who on one hand they know they need to change their eating habits, they know they need to increase their exercise, but they continue doing the same thing because it's familiar, it's known, and all. So again, they feel two ways about it, which is the deal with respect to substance use disorders. It might make their life horrible, but it's still known. It's still, you know, and for a lot of folks, they don't have a frame of reference to understand that it could be any way different than it is. So it's not so much denial. And again, denial isn't a bad thing. I mean, a lot of the folks that we work with who have substance use disorders are also trauma survivors. And denial has been what's kept them between the yellow lines for a while. And I often think about when I first got in the field, and the bottom, I mean, we were told, it's like if you sensed somebody had trauma issues, the whole deal was you were told your job was to get them sober. Don't even touch that. They can deal with the trauma issues later. And so we would take away the alcohol and drugs and discharge them from treatment, and then we'd wonder why they'd start using again. Well, it's like because you've taken away the one thing that was keeping them in between the yellow lines and not dealt with the underlying problem.
And you know, Ed, that is, that's a really good point. And I'm wondering, listening to you speak, this terminology, we've talked a lot about how it affects the person who's combating substance use issues. But I would say that it probably also affects the clinicians as well. So this idea of understanding and properly terming things, it helps with stigma and stigma, but I would also guess that it would help, appropriately terming would help with better treatment. So for clinicians to really think and view and understand what's going on, just like this example that you gave, I think was perfect of, taking away the substance without addressing some of the other issues, because a lot of this language has kind of been blame centered. But when you take that away, does it not, or does it open up the opportunity for clinicians to expand their thinking into other ways of treatment and other modalities
and
of service?
That's exactly it. And again, if I hurt anybody's feelings, I apologize, but from my experience, having worked in the field for as long as I have, a lot of times clinicians use the term denial to sort of, oh, well, they, just were in denial. They just, we can't do anything with them. They're in denial. They just need to get out of denial. To sort of absolve themselves of the challenge of digging a little bit deeper to find out what's going on with that person, what is, and this is where the whole concept of a recovery-oriented system of care comes in, as far as finding out what is it that that person needs to support their recovery within their own community. What is it that they don't have? And that's, it's one of those things, again, digging a little bit deeper, taking a little bit more time. It's like when a child isn't doing well in school, is it the child's problem, or is it the problem that maybe if the teacher was able to figure out, how's this child going to learn? How can we get through to this child and help them get better? And that's the point with denial versus ambivalence. One of the big things right now with respect to, especially this whole opioid issue, is this whole deal with respect to healthcare providers and the myths and misperceptions with respect to medication-assisted recovery. It's pretty much one of those deals that in the substance use disorder treatment field, very few people feel ambivalent about the use of medication. They either think it's a good thing or they think it's horrible. And one of the issues that, again, think about it in terms, and if they do think that it's okay, well, it should only be used for a certain amount of time. Most folks don't understand that the most effective behavioral, or the most effective treatment for diabetes and hypertension is behavior modification. It's exercise and diet. But the vast majority of folks who have those two issues are perfectly content to be on medication. Their quality of life is improved, and they're able to function, because in medical circles the primary goal is to keep somebody alive, and one of the things that a lot of times gets lost in the fact, if your bent is towards total abstinence, that's fine, but if somebody is dead, it's going to be awful hard to implement that. And medication, the use of medication for opioid use disorders, is effective. It just is, and again, that's not up for a vote. One of the things, again, the whole concept of harm reduction, which most substance use disorder counselors, you mentioned it, and they run screaming into the night. But again, look at it from the perspective of how many folks who have depression. We know the gold standard for treating depression is medication and cognitive behavioral therapy. How many folks are receiving antidepressant medication from their primary care doctor and they never get the cognitive behavioral therapy? Is their life better just being on the medication? Sure it is. Could it be better? Well, maybe, but the bottom line is their life is better. And, a lot of times those of us in the addiction treatment arena, we try to enforce our view of what recovery looks like on the folks that we serve. And if we're in recovery, we try to fit them into the same pigeonhole of what recovery program worked for us. Prime example that sort of helped me put it in perspective, I was doing a training in Asheville, North Carolina a couple of years ago, and a person shared that their brother, who'd been in recovery from alcoholism and involved in AA for 23 years. He owned a construction company, hired people in recovery, did service work, all of that stuff. Every morning when that guy got up, even after 23 years, he would take a 250 milligram antabuse tablet because he knew, what he said was that if I take this pill today, I know I'm not going to drink. Now, my takeaway from that was, would I want my recovery to look like that? My answer was no, but the flip side of that, was that working for him? Was his life better as a result of that? And, that was the important take-home. One of the things that has made me, I get very cranky about when people refer to folks who have opioid use disorder that are taking medication, that it's the easier, softer way. And it's like, would you say that same thing about somebody who had hypertension taking a diuretic? Well, if they would just make those behavior changes.
Right.
I mean, and along the same lines, thinking about a doctor prescribing, looking at somebody with hypertension, saying, okay, here's the deal. I'm going to prescribe this medication to you for 6 months. You better make those behavior changes, because if you don't, 6 months, that's it. You're on your own. Of course we wouldn't do that, but we do that with substance use disorders. And the deal is, right now, sure, the main medications on the shelf are for treating opioid use disorders, but more and more and more are coming down the line. One of the ones that's being looked at, too, is buprenorphine, which is the main ingredient of Suboxone, that seems to reduce cocaine cravings. Okay?
Right.
Go ahead.
And this is, and just before we move on to the next slide, this is a very intertwined relationship, I would say, between the modalities and payout systems for physicians and primary care doctors, and the difference in structure for payout and access to care, really, between chronic conditions that are widely accepted as chronic conditions and substance abuse issues, which we know fall under the same category of chronic conditions. Much to your point, that you wouldn't go to a doctor and they tell you we'll pay for 5 visits for your diabetes or hypertension issue, but that's it. You got to be better in five visits. But we do it all the time for substance use visits, and that could make it burdensome for the primary care docs who have moved beyond and are interested and willing to provide this care to be appropriately compensated for their care. So I think when we really think about how we want to shift as folks engaged in this industry who are looking to kind of keep the chronic condition-centered focus, I think it's important that we also remember that, it's a multi-pronged approach, really. That's necessary.
And I mean, I'll be honest with you, some major insurance companies, I think Kaiser is one of them, on the West Coast, is restructuring the way they reimburse, and again, for substance use disorders, to make it more consistent with other chronic medical conditions. And the good news is, which hopefully other folks will pick up on, is they're actually saving money by doing that.
It's very interesting that you say that, because I was involved in a Kaiser, long-term Kaiser grant that really looked at the integration of mental, behavioral, and addiction services into primary care settings. And what they found was that in addition to saving them money, it would be good for the quality of the life for the folks that they served. And they really did their homework, I got to say, around how to phase this in. And they've been successful in their Kaiser as an organization, as well as the folks they're serving, are really reaping the benefits.
Exactly. Something, too, that I think is important to point out, that, while I mentioned specifically medications to treat opioid use disorder, one of the things, and I mean this is still extremely prevalent in mutual aid groups, is the whole issue of someone who has a co-occurring mental health issue and substance use disorder, and folks commenting in recovery, commenting on the fact, it's like, well, you really shouldn't be on those things, because if you're not, you need to get off those meds because you're not really in recovery. And on a personal level, I get pretty cranky about that, because I spent the first 5 years of my recovery listening to those people, and I was clinically depressed. And when drinking wasn't an option, but jumping off the bridge was. So one of the things I'd like to get into now, if you look at it, is that is the word relapse. And granted, the word relapse is all over, you know, the big book Alcoholics Anonymous, but that's pretty morally judgmental. And I mean, and if you think about it, whenever I hear relapse, I always think about backsliding. And anybody who comes from a church background, backsliding is not a good thing. You know, and from the standpoint of what other medical condition, when somebody becomes symptomatic, are they referred to as relapsing? It's not used. Somebody becomes, you know, they have they have a setback. It's also something that just carries a carload of emotional baggage. I mean, and one of the things, especially, and then when we use, you know, and granted, I mean, you know, this is a treatment term, somebody who's a chronic relapser. I don't think there can be any more pejorative, judgmental term that can possibly be used. And I mean, and that's one of those things when I hear in mutual aid meetings, somebody, I mean, I'm pretty chill about, you know, I don't use terms, but I don't beat up other people. I do beat up other people for describing themselves as a chronic relapser. It's a chronic medical condition that might well be part of the process. Using a term like when somebody becomes symptomatic, that they've had a recurrence, they've had a return to use, or they've had a setback. You know, pure and simple. I prefer return to use. You know, I always think in terms, and I'm dating myself by saying this, as far as Dragnet, where Sergeant Friday would always say, just the facts, ma'am, just the facts. And that's what we're talking about. Cut all the moral silliness out and just the medical facts. Boom, period. And another one, there we go, clean and dirty. A lot of most addiction professionals, you know, we're pretty good about referring to urine drug screens as positive or negative, but every now and then we still slip. But again, you know, it's a medical test. You know, if you had some blood work done, would you expect your doctor to tell you it's like your blood work came back dirty? No, it came back positive or negative. But what's even worse, and this is, again, this is all over the place in mutual aid groups, referring to yourself as clean and sober. And I mean, I'm of an age where I remember when the opposite of clean was dirty, and dirty was usually something that preceded something that was either sexist, racist, or anti-Semitic, and it wasn't real nice. And it's not, it's, again, it's shaming, and it's not a more appropriate term is that somebody is either drug-free or free from illicit or non-prescribed medications. You know, and that's, and it's not so much that they're sober, they're in recovery. You know, and that's the point. Another one is this whole issue of the term overdose. And I'll be honest with you, I mean, I've been doing this for a while, and there's some term, probably one of the hardest terms for me to stop using was clean and sober, because I've been doing it for so long, as opposed to saying I'm in recovery. But one of the ones, and the Centers for Disease Control uses this, they don't use the term overdose, they use the term drug poisoning. Because, again, overdose implies, sort of like the term that addiction folks use all the time, when doing assessments as far as what is somebody's primary drug of choice. Well, the problem with that is, again, that it implies that it's a choice. Overdose implies choice, that someone consciously chose to take more than they were, supposed to. And we know that the vast, vast majority of cases, it's somebody didn't make a choice to do that. It's a result of a combination of medications. And it's the same way as, we use the term drug of choice. What we're looking for as clinicians is what was the primary drug or substance that they used the most of? So using the term,
Exactly.
what was somebody's primary drug of use? Is, again, it's much more accurate and much less pejorative. And last, before we head into questions, I guess, the thing that I feel pretty strong about is using person first language. I am a person who, and again, this sort of started with the whole, HIV/AIDS, as far as it's not an AIDS victim or an HIV person.
Mm-hmm.
It's a person who's living with HIV or a person with AIDS. Looking at it from the standpoint that somebody's a person first who has a medical condition, period. Okay? So looking at it from the standpoint of and again, mental health is a lot further along with this than substance use is, from the standpoint of, somebody is so-and-so is schizophrenic. No, it's a person with schizophrenia, or a person with bipolar disorder. But it's a person.
Exactly.
I'm a person who has a substance use disorder, or what I tend to prefer, I'm a person in recovery. I don't define myself. And one of the things, too, and this is, again, where mutual aid groups and a lot of times folks in treatment, referring to themselves as a crackhead, referring to themselves as, a junkie, referring to themselves as an addict. I will never forget that a medical school that's in my hometown, the requirement for folks to become familiar with substance use disorders is they have to go to one open AA meeting. And at this one particular meeting, there were like 5 or 10 medical students, and this one old gentleman who I knew got up and to speak, and he said, well, I'm just an old drunk, and I've been coming around here for years, and all I know is, and you could see the medical students' eyes get wide, and you knew that they were thinking, it's like, he's still a drunk, and he's been coming around here for years? What in the world is he still doing? And the whole point is being aware of how somebody who's not, I knew what he's getting at, but folks who aren't familiar with addiction, the general public, they don't understand that. So pretty much that's where, where we're at. I guess is now the time where we shift to open it up so that Mr. and Mrs. America and all the ships at sea can ask questions. In case you couldn't figure out, I'm having a good time. I hope the folks who are listening are having a good time.
Takes 2 of us.
A gentleman posted asking the question. It's with respect to something the Harm Reduction Coalition came up with, that it's not a disease. It's really it's one of those things. If you want to get totally specific, what it basically is the fact it's the limbic part of the brain is dysregulated, and while genetics plays a part in it, there are also a bunch of other predisposing factors that can contribute to it, one of which is stress. So it's one of those things that there are a bunch of different things that come into play, but the bottom line is that viewing it, what's problematic is when it's viewed as a choice and not as something medical. And let's see here. I hope that answered that. Well, I'm, the question of are we changing the language because of who's becoming affected with it? I don't know if I would say that. I've been beaten on this for about 7 years now, and that was really before the big epidemic. Basically, it's appropriate regardless of who has it. I mean, regardless of what their skin color is or their socioeconomic status. It needs to be addressed. If it's a medical condition, a medical disease, a medical whatever you want to call it, it needs to be, the terms need to match it. A big problem, and this is something that's real important for folks to understand, a big issue, a big thing with stigma very much also is the fact that if somebody, because of the stigma, and I don't want to be like those people, that keeps people from seeking help. That keeps people out there, and so the whole issue is if you want people, and an example I like to use is if folks would view, think back in terms of breast cancer. And I remember when, back when breast cancer, I mean, it's a lot of shame, wasn't talked about, and then Betty Ford, the president's wife in the 70s, when she had breast cancer, she started talking about it. And if you look today at the way breast cancer is addressed and the issue of screening, more importantly, the issue that people talk about it, to where if somebody thinks they might have something going on, there are all sorts of people in their life that they know that they can talk to who are breast cancer survivors. There's all sorts of educational programs, fundraisers, all of that, but it's normalized. It's not, people avoid being screened because, oh my God, if I got it, I don't want to, there's nothing you can do about it. So that's the deal. Somebody else brought up the whole issue of does this have to do with pharmaceutical industry? Nah. I mean, again, it has to do with the fact if it is medical, we need to use medical terms. It's just that simple.
And I like to bring up too that disciplines go through periods of shift, right? So I think this is a period of shift in the way that we talk about and subsequently treat folks with substance use disorders. So I don't know that this shift is any different per se than in some of the other disciplines where you learn more, so you do things a little differently.
One of the things somebody just brought up, the whole issue of in a medical setting, in a primary care setting, where you have physicians. One of the things that's important to understand about the whole issue of screening is it would be better served because, again, the way, with limited amount of time, it would probably be much more effective if a nurse or if, just to do, because the screening is just a simple, how many drinks of alcohol have you had in the last 7 days and how many at one sitting? And then based on that, they could be referred to somebody, preferably in-house, to further screening. But that would be not so much the physician, even though if the physician were to bring it up, or a nurse bring it up, that might bring up the awareness to where somebody can, again, get screened, but not, again, using a lower level medical provider than the physician. Somebody just asked the question of when if we use the phrase somebody has an alcohol problem, I will share, from my personal experience, my father was very much an alcoholic, and my mother was still, it's like, well, your daddy has a problem when he drinks. It's like, no, Mom, he's an alcoholic. It's sort of a nice way of phrasing it. Again, looking at a more accurate term for it is that does somebody have is it problematic use? Okay, is somebody's use of alcohol problematic? and that can be, severely problematic. Again, looking at, used to we had abuse and we had dependence, and you had use, abuse, and dependence. The beauty of substance use disorders now in the DSM is that you have mild, moderate, and severe, and that's an important thing to look at. Somebody also just brought up the whole issue of if somebody is taking opioids or benzos, being referred to a pain management clinic. One of the huge challenges with people who have legitimate pain is effectively managing that pain without increasing the problems with respect to their substance use disorder. And one of the things, and this is something I'll be honest with you, research has demonstrated that probably the vast majority of people who have quote-unquote pain issues, it's not just physical pain, but it's emotional issues that have not been dealt with. And if you can deal with those underlying, emotional issues, you can reduce the need for somebody to be on pain meds. But unfortunately, the problem being that a lot of the folks, when they first show up for treatment, they don't see that they have emotional problems. And again, you have to have that therapeutic relationship before you can get into that. So it's like, yeah.
So in the interest of time, I'm sorry, in the interest of time, I'm going to say that the next question be our last question.
Oh, yeah.
We got to do we also need to leave some time for Tabitha.
Got to do the, let's see what we got here. The question of what's the most effective way of changing people's language, and basically one of the things you can act, I'm a firm believer of the phrase, it's better to light a single candle than to sit and curse the dark. I can be an example. I don't need to beat up on folks, and a lot of times people will pick up on that. One of the things too is we as providers can use appropriate terms and help the folks that we're working with, not beat them up when they use those stigmatizing terms, but help them get it why there might be more accurate terms that they can use. But it's a process, and it's a matter of I've had folks refer or talk about the fact that they use the language of recovery thing in clinical supervision, and it sort of becomes an issue. I'm doing a 3-hour training week after next, or actually next week, for some folks that. Again, looking at it, and it's the matter of increasing awareness, because so many of these terms, people just haven't thought about it. It's like, wow, I never thought about it from that perspective, but maybe that's more accurate. As you can tell, I could probably go on talking for another 4 hours and 15 minutes just staring at this computer, but as my colleague Larissa pointed out, we've reached the end of our time. My email address was on. I guess they can get in touch with this or my email address, and I'd be more than happy to to provide any other input. It's again, it's Ed Johnson at MSM, as in Morehouse School of Medicine.edu, because I think this is a pretty important topic. So with that, I'll turn it back over to Larissa. Thank you all for being here.
Yes, great. We do have some next steps for you where we would like you to fill out an evaluation that we're going to be sending you shortly. Just to get some feedback about today's webinar so we can, get some information from you and do some things moving forward. The other thing we want you to be on the lookout for is the archive webinar recording for today's presentation. We also do have the presentation in the files pod just below the bottom of your screen, where you can also go ahead and access the presentation today as well if you want to go ahead and do that, as well as one of the references that Mr. Johnson referenced today as far as language and recovery. You can access some resources there as well in the files pod. And then we've also got several webinars that are coming up in March that we would love for you to join us on. March 16th, we have a webinar with the Centers for Disease Control and Prevention, and that webinar will be What We Know About E-Cigarettes. And then the next webinar for SATTC is March 22nd, and that one will be Understanding Opioid Disorder and Medication. And again, I want to thank you all for joining us today. Please be sure to visit the Primary Care National Center for Primary Care website at www.primarycarematters.org, as well as keep up with us on Twitter as well. And Larissa, anything else from you?
No, thank you guys for being here. It's been a pleasure, and I think it's been informative dialogue. Thank you for your questions.
Thank you all very much for your questions. They were good questions. We just didn't have enough time.
Thank you, everyone, and have a great evening.